Hello everyone, my name is Bereket Negassi. My presentation is regarding care management of chronic constipation. The reason I'm interested in this case is because I used to work in an emergency department, and a significant number of my patients who come from long-term care facilities present in for chronic constipation, and we usually give them or provide subset enema, but I always think of what can be done to support the long-term cares. So as an introduction, this presentation focuses on the care experience of an 88-year-old female presenting with chronic constipation and care-related concerns. The patient complains of straining during bowel movements. The patient reports having bowel movements once or twice a week, and the patient reported that she does not like the food served by the facility and had to order outside food. And the patient also reported concern with taking laxatives because she worries of being a burden to caregivers related to frequent cleanups, and she worries about skin irritation caused by loose stools and may result in pressure ulcers. And then we'll also discuss about the pharmacologic and non-pharmacologic plan of care. So I have two key objectives and takeaways. And the first one is chronic constipation among patients in long-term care facilities. And I will use the article by Miyamura. And this discussion will point out physical and nutritional factors causing constipation, medications that can possibly cause constipation, environmental and social factors contributing to constipation, cognitive and psychological factors resulting in constipation, and healthcare burden of constipation. So, and the second key objective is addressing underreporting of symptoms and subjective patient concerns. And this will be also a review of a similar article by Miyamura, and based on underreporting because of patient concerns and a fear of requesting laxative and related to stool causing skin irritation, and worry about being a burden to caregivers. And then this underreporting is leading to delays in getting help. So just wanted to see the extent of this problem if it is happening systemically. So let's first define constipation. According to Sharma, constipation is pointed in about four criteria. First one is stool retention, causing difficulty in defecation, having fewer than 3 bowel movements for over 6 weeks, straining during defecation, and incomplete stool evacuation and sensation of anorectal obstruction. So let's talk about my patient. The patient's chief complaint was chronic constipation with straining during bowel movements. And subjective notes include patient is an 88-year-old female residing in a long-term care facility, presents for constipation. Her reported that she is bedridden and receiving total care. Patient reported straining during bowel movements and in the previous day, which was about 4 days ago, and worries about the next episode of bowel movement. And patient denies rectal bleeding, abdominal pain, nausea, vomiting, or hemorrhoids. And patient reports hesitancy about reporting due to worry about the effect of laxatives. And patient also reports disliking the food served by the facility and frequently has to order outside food, or mostly it's salting crackers when hungry. And the patient's medical history includes chronic constipation, hemapheresis of right dominant side of late effect of cerebral infarction, colonic polyps, hypothyroidism, pressure ulcer of the sacral region, stage 1, and severe dementia. And patient have a family history of dementia as well. So the objective data includes vitals, temperature 98.1, blood pressure 120/63, heart rate 61, oxygen saturation 96%, and patient was breathing 16%, 16, respiration 16, sorry. And generally, patient is alert, mildly anxious, cooperative, bedridden. And neuro-wise, patient is left-sided weakness noted during exam, no acute neurological changes from her baseline, and lungs are clear to auscultation bilaterally, and no respiratory distress. And cardiovascular with the regular rate and rhythm, normal S1, S2, and no peripheral edema. And GI, abdomen is soft, no non-distended, bowel sounds present, no tenderness, no guarding or rebound. Rectal, patient refused rectal exam, but stated that she is no bleeding or hemorrhoids. It's difficult to know because patient is total care. According to Rome 4 criteria, the patient has two of the many stated diagnostic criteria, which is her report of straining during bowel movement for more than 25% of defecations and fewer than 3 spontaneous bowel movements per week. As a result, her assessment is chronic constipation with straining during bowel movements. ICD-10 is K59.09. So now let's talk about these research articles that supports the diagnosis criteria or assessment criteria. The article by Miyamura cited the Rome 4 criteria, which is the patient exhibits some of them, and which includes straining during more than 25% of defecations, lumpy or hard stool, sensation of incomplete evacuation, sensation of anorectal obstruction, and manual maneuvers needed to facilitate defecations, and fewer than 3 spontaneous bowel movements per week. So according to the same article, the study design is a narrative review of randomized controlled trials and large prospective cohort studies and cross-sectional studies consisting of 242 articles involving older adults. The aim of that article was to identify secondary causes of constipation, factoring in age, neurological disorders, cognitive impairment, lack of physical activity, inappropriate defecation posture, and polypharmacy, including opioids. And the article concludes that comprehensive individualized care management is very important. And the article also recommended that considering beyond, we should consider care for the patient beyond the use of laxatives. And then we'll also discuss the second article by Van der Schoot. And according to this article, fewer than 3 spontaneous bowel movements per week, straining during defecation, and chronic constipation is a prevalent disorder and poses challenges in resolving in the condition. Given that the patient is eating outside, this is helpful to review articles supporting dietary or supplemental approaches. So according to this article, again, this article is a randomized controlled trial with 1,251 participants to identify if fiber supplementation is effective. Because I think they are recommending that systemically long-term care facilities can add fiber supplementation in their diet plans. And according to this article, results show that fiber supplementation increased stool frequency with 95% confidence interval, which indicates that most of the samples show a true effect, and then a p-value of 0.0001 indicates statistical significance. Therefore, considering the prevalence of chronic constipation, fiber supplementation can be added to the diet plan. And I also reviewed the third article by Zhang, and Zhang is talking about risk factors as well, which includes nursing home residents, advanced age, medical complexity, polypharmacy, insufficient fluid intake, and impaired mobility. The article by Zhang reports on two retrospective cohort studies conducted in parallel across 125 nursing home facilities. This is a large research article. So the objective is to evaluate the burden of chronic constipation and the use of drugs to treat it. So results show that electronic health record identified 25,739 patients with chronic constipation. But in actuality, a total of 245,578 patients had chronic constipation. A little more than half, or 55% of the residents, were prescribed laxatives. Therefore, the article concluded that a gap in documentation of or addressing patient condition, because the electronic health record identified very small amount of patients who are with chronic constipation. So I have a differential diagnosis, which is a rule out of colonic polyps, because the patient has a chronic colonic polyps, and which can cause physical obstruction and block stool flow. So therefore, it's good to know about what are the symptoms of colonic polyps, which includes changes in bowel habit, rectal bleeding, patient denies it, abdominal pain that does not go away, patient denies that, and the family history of colonic polyps or colon cancer. And this data, we don't have this data. So if these symptoms start to occur, or if these symptoms are warranted in a next visit, I think colonoscopy will be ordered. And the treatment plan, non-pharmacologic treatment plan, was to encourage fluid intake of 2 liters a day, monitor bowel frequency and stool consistency, and report. And pharmacologic includes discontinue loperamide, oral liquid 1 milligram, 7.5 ml. Somehow the patient had this medication, which would cause constipation, and we started immediately biscoidal 10 milligram rectal suppository, and order Senna 8.6 milligram, 2 tablets by mouth as needed twice a day for constipation. And if no bowel movement in 2 days, hold for loose stools. And treatment plan supporting articles include for non-pharmacologic plan are initial steps of management, which are very important, and which is increase fluid intake and increase dietary fiber and exercise. Pharmacologic treatment options include fiber or osmotic laxatives such as polyethylene glycol, magnesium oxide, and lactulose. And stimulant laxatives include biscodyl, sodium picosulfate, and Senna. And secretags include lubiprostone, linaclotide, and placentide. And then the other pharmacologic option we have is serotonin type 4 agonist, which is prochlorpride. Okay, so we just want to make sure, and during this presentation we address the our objectives. So let's talk about risk factors. So medication, this patient takes medications such as loperamide, and statins that can cause constipation. And when we review environmental or social factors, patient has restricted access to toileting because she's total care and bedridden, and she cannot move herself. And then she has a loss of independence, age-related physical decline, and cognitive and psychological factors include diseases such as dementia. And according to Miyamura, which conducted narrative review of 242 articles addressing constipation in older adults, that constipation is associated with reduced quality of life, functional decline, frailty, and risk of cognitive impairment. And according to the article, medications such as opioids increase the risk of constipation. Cognitive function is another risk factor for constipation, and psychological factors such as depression can be related as well. So the study design is Miyamura designed randomized controlled trials of 242 articles, as we said earlier, with the aim to identify secondary causes of constipation, factoring in age, neurological disorders, cognitive impairment, lack of physical activity, inappropriate defecation, posture, and polypharmacy, including opioids, concluding that the comprehensive individualized care management is needed for this kind of patients. And Zhang ETAL conducted two retrospective cohort studies of 126 nursing homes housing 245,578 residents, in concluding that the burden of chronic constipation is high among nursing home residents. Narrative review of randomized controlled trial large perspective cohort studies and cross-sectional studies involving older adults addressing the subjective concerns, comprising 242 articles. Patient also has also addressed concerns consistent with the study. A fear of requesting laxative related to loose stools causing skin irritation, and worry about being a burden to caregivers, and underreporting leading to delays in getting help. The article by Miyamura actually and Zhang follows two retrospective cohort studies, I said earlier, and in parallel of 126 nursing home facilities, with the objective to evaluate the burden of chronic constipation and use of drugs to treat it. The study revealed that economic burden due to lack of resources, humanistic burden such as emotional distress and frequent disruption of daily routines, cognitive impairment and limitations, and treatment-related onset of fecal incontinence, which cause reduce in participation with care. So in conclusion, caring for a similar patient population requires an individualized care plan and addressing patient concerns and preference, improving treatment outcome. So for this reason, for the facility, actually addressed the patient concern that she doesn't like food. So we ask them to review the food preferences and add fiber on the diet, and combining pharmacologic therapy with evidence-based non-pharmacologic strategies yields favorable outcomes. Patient and caregiver education is essential here to reduce fears and encourage adherence and promote participation. And ongoing assessment and follow-up help prevent complications. So we actually teach about the history of considering if a patient has colonic polyps, and to report if she has a symptom of any bleeding and continuous abdominal pain, and if there are changes to report, so we could order the colonoscopy. And then the other thing is we need to have compassion and multidisciplinary option to help the patient, which includes, when we say multidisciplinary, we can add nutritionist here and yeah. So my reflection of this presentation of this patient condition is in case of dietary fiber and fluid intake by including patient's preferred food. Increase dietary fiber and fluid intake by including the patient's preference, which increases her dignity. And develop a bowel routine to reduce constipation and laxative dependence, and involve a dietitian to improve nutrition using available facility meal options, and provide extensive patient and caregiver education to improve treatment adherence, and schedule regular follow-up visits to adjust therapy and prevent unnecessary interventions. And then would like to refer to studies from the literature to formulate and modify the care plan. So I have two posing questions for my fellow students here. First one is, how can advanced practice nurses help improve adherence to care in older adults with chronic constipation who live in a long-term care facilities? And my second question is, non-pharmacologic interventions are considered first line. What would you suggest be added as a non-pharmacological care plan for this patient? And actually, for me, one of the things I provide to my patients in my acute care clinic is prune juice. So usually that gives me a good outcome. So let me hear what you can say about non-pharmacologic interventions. These are my references, and thank you for listening, and hope to hear or learn from your comments and questions. And thank you very much.